So before we can talk about neuromuscular blockers, let's first talk about our nerve transmission. And so we'll describe a cell body here that normally originates from your spine, from your ventral horn that we talked about because we have corticospinal tracts leading down the spine. And this has an axon leading to our nerve fiber on our motor unit. And so this is our whole motor unit. And so our conduction goes down our axon and then down our tiny axon, eventually down to our motor unit end plate. And here's where we end up seeing our neurotransmitters being released into our synapse and then eventually leading to our final muscle contraction. But what I want to mention here is that this whole thing is our motor unit. And we actually end up having many synapses that have multiple motor end units or end plates at different points on the muscle to lead to our full contraction of this motor unit. And so this all contracts all at the same time to be a very concerted contraction. And before we are even born in our fetal development, we have multiple connections to our muscle unit, but eventually over time, before we're born, these degrade and we're left with just one. And so we can follow our nerve conduction down our axon to our muscle and then down to our synapse, and we'll just draw our synapse here. And so here we have our presynapse, and our postsynapse. And so we end up having a nerve conduction drop down to our nerve terminal, meet a voltage-gated calcium channel. So this is voltage-gated. It is a P voltage as opposed to an L voltage gated channel, which we'll talk about why that's significant later. But this leads to intracellular calcium increasing quite a bit into our nerve terminal. What ends up happening is that we have our vesicles here that house acetylcholine. And so we have two types of vesicles in our nerve terminal. We have a reserve pool, which is more into the cell or into the middle of the nerve terminal. And then we have other vesicles here at the edge, which are more for immediate release. And so these immediate releases are potentially immediately facilitated by this increase in calcium. And so what we have here is a docking protein that's facilitated by calcium to bind to our nerve terminal synapse and eventually release our acetylcholine. So this is acetylcholine into our synapse to eventually bind to our postsynapse. And so here we have acetylcholine receptors. So this is a ligand channel. And this leads to our ions moving down into this nerve cell and leading to voltage-gated sodium channels helping to conduct down this motor unit and into the T-tubule system and finally leading to our sarcomere mobilization and contraction. And so we'll point out a few things about this. So originally we have acetylcholine receptors kind of everywhere on our muscle cell, but over time, before we are actually born, these tend to migrate to our motor end plate. And so what we'll say is that these get very dense. And so we'll call these active zones. Active zones. And so here we have a significant amount of acetylcholine receptors to facilitate our contraction. And so we have about 5 million receptors here. And we only need probably about 0.5 million for actual activation signal. And I'll just mention a couple things about these vesicles here. So these vesicles release a certain amount of acetylcholine, and they're called a quanta. So a certain package or a certain amount of acetylcholine to be released, and this is in the neighborhood of 5 to 10,000 molecules of acetylcholine. And when we have a calcium triggered response, we have about 200 to 400 vesicles fused to that surface, releasing their acetylcholine, which means that we end up having about 1 to 4 million acetylcholine molecules released into that synapse space, all around here, and potentially acting on all our significant number of acetylcholine receptors. And so what this leads to is incredibly sensitive or very easy activation of our muscle unit. And so we can say that there's about a 10-fold ability for a margin of safety to ensure that we actually end up getting our muscle contraction. So there's a 10-fold margin of safety. And then as well, when we count up all our vesicles in our nerve terminal, we have a significant number. We have about 75 to 100,000 vesicles. And so what we can say is essentially only a very small fraction even fuse to the surface, which means that we can potentially have multiple stimuli coming down that nerve cell and still having the acetylcholine be available for release and eventually having our muscle contraction. So we can have extremely quick or repetitive nerve stimulation leading to muscle contraction, and this could potentially even lead to tetanus or tetany if you end up having too many stimulations occurring too frequently. We find that a bunch of acetylcholine is released into the space and binds to this acetylcholine receptor. Now we can draw our acetylcholine receptor a little bit more zoomed in. So we can label our receptor channel here as acetylcholine. So we can see from a top view that we have 5 proteins that make up this channel. And so what we have is we have a alpha 1, we have 2 of them, we have a beta 1, we have a delta, and we have an epsilon. And so this is important because we'll talk about different types of nicotinic acetylcholine receptors that have different arrangements and may have different sensitivities. But what we end up having is this acetylcholine ligand channel, not a voltage-gated channel, that binds acetylcholine, and it needs to bind on these alpha subunits. And 2 acetylcholines need to bind before we can have activation of this channel. And what ends up happening is we end up getting sodium and calcium rushing into the cell. And we have potassium rush out, which ends up depolarizing a cell and leading to activation of a second type of channel, and we'll call this a sodium channel. And so here we have sodium extracellular that's built up because of a ATPase pump that rushes down its concentration gradient when the channel opens to then depolarize further. And so this is a voltage gated channel, which is different from our ligand channel with acetylcholine. But this depolarization of our acetylcholine receptor leads to eventual depolarization of our sodium channel to then lead to our propagation of our action potential going down the nerve cell. And so 2 things I want to mention about this sodium channel is that there's 2 gates that we can think about for this sodium channel. And so we can say that these are gated based off 2 different factors. We have voltage gating one of our gates, and the second one being time. And so in the normal resting state, our time gate is open, but we still have our voltage gate that's closed. And so there's no ability for sodium to wiggle down past these 2 gates. But when we have depolarization of our acetylcholine ligand beta channel, we end up having depolarization of our cell leading to the voltage from minus 90 millivolts, jumping up and passing our threshold of minus 70, at which point our voltage gated gate opens up. When both of these gates are open, sodium can wiggle down, and once sodium is in the cell, it can lead to further depolarization and propagation of our nerve signal. But about 1 millisecond afterwards, this gate eventually closes again. Which means that we eventually lead to our sodium not being able to enter the cell. And this eventually leads to our repolarization. And until our cell actually repolarizes, this gate will stay closed. Now, the last thing we'll mention here is that there's also a pre-junctional acetylcholine receptor. So there's post-junctional and pre-junctional receptors. And they've found that these receptors are a little bit different in that their makeup is made of alpha 3 and beta 2, as opposed to our normal alpha 1, beta 1 nicotinic acetylcholine receptor. And what it's thought happens is that this potentially leads to more calcium coming into the cell and releasing further vesicles into the synaptic space for acetylcholine. And in this way, it's thought that these pre-junctional receptors might have some amount of positive feedback. And potentially mobilization of our reserve vesicles or reserve pool vesicles. So after we have our acetylcholine bind to our receptor and lead to our propagation, we have its breakdown by these little stalks holding acetylcholinesterase, which is essentially incredibly close to these acetylcholine receptors and are very easily able to break down acetylcholine into its breakdown products, choline and acetyl-CoA. And these stalks holding acetylcholinesterase are essentially in between these receptors, and so the acetylcholine molecules that are released in the synapse do bypass these stalks to get to the receptor, and so there's a little amount of breakdown before it can potentially even get to this receptor. But because we have such a close space and such a close active zone of acetylcholine receptors, and we have such a significant margin of safety because of that tenfold amount of acetylcholine released into the space than actually necessary for activation, we end up having quite a significant ease of full activation and motor contraction. So now let's talk about our neuromuscular blockers. And so we have two different types. We have our depolarizers and our non-depolarizers. And the only depolarizer that we currently have on the market is succinylcholine, or Sux. And as far as non-depolarizers, we have a significant number that we can potentially use, but the most common thing that we're using in day-to-day ORs is ROG. And so let's describe both of these actions and what happens at the site of. And so what's specific about succinylcholine is that it's actually two acetylcholine molecules bound together with a bridge. And so this can act very similar to acetylcholine in the sense that it can still activate our acetylcholine ligand channel. And so succinylcholine comes to bind here and attaches to the same site as our normal acetylcholine. And because it has two acetylcholine molecules attached to the bridge, it can bind to both of these sites and essentially create that conformational change to activate this ligand channel. Now, when Sux binds to this channel, we do get this hyperpolarization just like our normal action potential would occur with acetylcholine binding. And this would then lead to our voltage-gated gate in our sodium channel opening up, and because our time gate is open at rest, we can end up having an influx of sodium into the cell, which would then lead to further propagation. And we can define these as three different parts of the motor unit. So we'll say that this first part is our end plate. And we can say our second part is our perijunctional receptors, which leads to our voltage-gated depolarization and further propagation to our third part of our cell, which is essentially these non-junctional receptors, which promote our propagation down our cell into our T-tubule and leading to our contraction. Now, what ends up happening is that because this succinylcholine molecule isn't broken down by our acetylcholine esterases here beside it, it stays in our space and in our synapse and stays potentially bound to our channel. And if it stays bound to our channel, we stay in a depolarized state. So we'll say that our end plate stays depolarized. And due to our maintained depolarization, our time gate ends up closing and inactivates. And so we'll say that our perijunctional space inactivates. And so we don't end up having more ability for sodium to jump into our cell. And due to that, we end up not being able to propagate depolarization across our cell membrane down into our non-junctional space here. And so even though we had a fasciculation and muscle contraction due to original binding of succinylcholine, we essentially return our non-junctional part of our cell back to our resting state. And so this actually stays in a resting state. And so we can think about our succinylcholine mechanism action as having three different spots: our end plate, and our non-junctional space of our motor unit. And so this is described as our classic description of how succinylcholine works to deactivate our muscle unit and end up not being able to have a continuous contraction. And this barrier between our perijunctional space and our non-junctional space is essentially what we'll describe as accommodation. And so accommodation is what ends up leading to our idea that we end up having a barrier between the ability for our synapse to potentially activate our receptors and lead to a neuromuscular transmission. And there's a few different ways in which this can happen. And so accommodation can occur at least classically or potentially through non-classical mechanisms. So non-classic. And third, it could potentially happen due to And so we'll first talk about our non-classic mechanisms. And so the biggest one that we see, especially in succinylcholine, is this concept of desensitization. Desensitization. And so this is the thought that even if you give more acetylcholine into this space, you may not be able to induce a conformational change into this protein to ensure that this channel opens up and you end up having some amount of flux in of our ions like sodium and calcium. And so there's potentially a lot of different sites at which we may have certain types of drugs or substrates in the body that might be able to change the way that this conformational change occurs, which might not even fully close off this, but might even lead to a slower reaction to our channel or potentially insensitivity to how much acetylcholine is necessary. And so a number of our agents can potentially do this, including volatiles, barbiturates, even our agonists like acetylcholine itself can potentially desensitize our channel. And we know for sure that succinylcholine has the ability to desensitize our channel. And as well, we know that acetylcholine esterase inhibitors that we might use for normally reversal of a patient is also being implicated in this desensitization, as well as even local anesthetics and calcium channel blockers. Now, there's another way that some of our drugs can block it, and this is through direct channel blocking. Channel block. And so this is where our molecule ends up sitting right in the inner part of this channel membrane only when the channel membrane is opened so that the drug can actually enter into that inner part of our cell channel. And this is how our local anesthetics and calcium channel blockers normally work. And so what we can even say is that this is a use-dependent block. And use-dependent means that it actually has to be activated first with our normal agonist, like acetylcholine, to open up this conformational change to allow our molecule to potentially bind inside the other part or on the inner part. And the third way that we might end up having a block is through our pre-junctional synapse. Pre-junctional. And what we might end up happening, and so what can potentially happen is some of our drugs may actually act on this site to potentially decrease our calcium into our nerve terminal and reduce our ability to mobilize our quantas or vesicles and let them release to our synapse. And then finally, I'll make a note about our potentials for different types of nicotinic acetylcholine receptors, and that some of them have a slightly different way of having accommodation. And so there are two different types of acetylcholine receptors that we didn't mention. And so there's an immature version of our acetylcholine receptors, which instead of the epsilon, we have a gamma. We have a gamma subunit. And so this immature channel is what we end up having as a fetus, but then turns into our mature form and into an epsilon subunit. However, we can still have some of these immature receptors in some extra junctional spots on our motor unit. And so we can say these are our gamma subunit immature nicotinic acetylcholine receptors. And the second type I want to mention are these potential non-junctional receptors that are called alpha 7. And these receptors are a little different in the sense that they have 5 alpha 7 receptors and no other types of other subunits involved in it. And so this is actually A7, and there's 5 of these subunits. And so these non-junctional alpha 7 receptors are a relatively new finding in higher density compared to other types of tissues. And so one type of tissue that has found both of these types of receptors is our ocular muscles. Ocular muscles. And what's special about these is that they happen to have an inability to accommodate, which means that when we give our succinylcholine to these tissues specifically, we end up with a longer depolarization and a longer contraction. And so what we can end up having is several minutes, so potentially 3 to 7 minutes of sustained contraction. And this is where the thought is that with succinylcholine, we may have an increased risk of intraocular pressure because we have a sustained contraction and tension in our muscles around the eye, leading to a potential risk for extrusion of our vitreal components if we have an open globe injury. Now, these drugs work on acting on the exact same acetylcholine ligand channel, but they'll bind ligand site, but not induce our conformational change to sodium or calcium into the cell. We only need to block one of these receptor sites to block the idea of a conformational change occurring with acetylcholine. And this is because we need both sites to be bound with acetylcholine for us to have our conformational change in our channel. And so even though we end up having a significant margin of safety as far as how much acetylcholine is released into the space and potentially necessary for triggering a contraction, What is potentially useful is that ROCK only needs to bind to one part of the site to potentially have, as much as this only needs to bind one site, you probably still need 75% of receptors to be bound before we can end up having appropriate neuromuscular blockade. And so they say that essentially our dosing for rocuronium for initiating our neuromuscular block is much higher than potentially maintaining our block, because once we have a certain amount of rocuronium on board, we only need a little bit more to potentially get to our. And second, ROCK is a competitive antagonist. This is competitive. And so if we have enough acetylcholine into this space, it can potentially displace rocuronium and bind and have a normal conformational change in depolarization. And so this is where our concept of giving acetylcholinesterase inhibitors will end up overloading the synapse with more acetylcholine to outcompete our ROCK. And this is different from our succinylcholine, where this is a non-competitive form of blockade or classic blockade, where we end up having an inability to concentrate acetylcholine into that space to potentially overwhelm those receptors and lead to. So now that we know the difference between our depolarizers and our non-depolarizers, let's look at comparing them in the form of blockade, termination, reversal, and nerve stimulation. So, all right, blockade, termination, reversal, and nerve stim. So first we'll talk about blockade. And so we know that rocuronium is our competitive blockade. And so that means that when ROCK binds to this channel, that it can be outcompeted by acetylcholine if we raise that acetylcholine level potentially. And so they are binding at the same site, while succinylcholine is also binding at that site, but it's having two molecules binding to it, and it continues to stay bound to it because there is no ability for an enzyme to break down succinylcholine in this synapse, because acetylcholinesterase can't break down succinylcholine. And so we have a non-competitive block. And we know for non-depolarizing agents, they're often broken down by the liver and excreted either through the biliary system or the kidneys. And so they just have a normal degradation, and this can be extremely long, like pancuronium, or relatively short, like rocuronium or vecuronium. And when we compare this to potentially succinylcholine, we know that this space has acetylcholine here in these synaptic clefts, but we don't have any ability to break down succinylcholine because it has these two acetylcholine molecules with a bridge. And so this drug needs to diffuse away from the space and eventually hit our bloodstream to be broken down by pseudocholinesterase. And so this is found in the plasma, and so often it may be called plasma cholinesterase. And so our pseudocholinesterase enzyme ends up being able to break down succinylcholine by breaking down this bridge and ending up in our two metabolites of two acetylcholine molecules. And so another point about this is that when we end up giving succinylcholine, we have to give a very large dose of succinylcholine because there's such a significant amount of pseudocholinesterase in our blood that actually only a very small fraction ends up getting to our synaptic space to be able to block these. And so one of the things that we have to keep in mind is that for succinylcholine, we have to give total body weight dosing. And that's because we have to give amount of pseudocholinesterase enzyme is related to the amount of blood volume that a patient has. And this is different from maybe our dosing of non-depolarizing agents, which are often dosed lean body weight. And so succinylcholine will be broken down by our plasma. And so it doesn't have termination based off getting to our livers or in the kidneys, but more just diffusing to our plasma. And then this moves us to our next topic of reversal. So as we know, we have a competitive blockade with rocuronium, which means that if we increase our acetylcholine in our space, we can potentially outcompete our rocuronium and bump it off and end up having rocuronium diffuse into our plasma and eventually lead to our liver for breakdown and excretion. And so this responds very well to acetylcholinesterase inhibitors. And these esterase inhibitors will end up blocking our ability to break down our acetylcholine in the space, leading to far more acetylcholine in our synapse being able to respond with our acetylcholine receptor. And so this is different from our depolarizing succinylcholine drug because we don't end up having a competitive blockade, we have a non-competitive blockade, which means that we can't actually increase our acetylcholine in our space to outcompete our succinylcholine. And if anything, we know that acetylcholinesterase inhibitors can potentially desensitize our receptor channel to the idea of an agonist and lead to further block. This, along with the idea that acetylcholinesterase inhibitors might increase acetylcholine in our space, which has also been known to increase our blockade or desensitize our channel. And thirdly, we know that acetylcholinesterase inhibitors actually inhibit pseudocholinesterase as well, which means that all of these mechanisms together can potentially worsen or make our blockade even worse if we were to give our standard reversal agent that we think of for rocuronium or our non-depolarizers. So they don't respond well, and or they may even make your block worse. And so clinically, this might become harder to decide what you might want to do if, let's say, you've reversed the patient with acetylcholinesterase because you've given them, let's say, rocuronium during the case. And then upon emergence, if you maybe have laryngospasm or an inability to ventilate or oxygenate and you need to potentially re-intubate this patient, you now have a difficult situation because if you want to quickly intubate them, you may decide to give succinylcholine. But because you've just given acetylcholinesterase inhibitors, you have a further potentiation of your block if you're to give succinylcholine, which means if you're to give it, you may have to provide further ventilation to this patient because you know that this succinylcholine might take much longer than the standard 8 to 10 minutes to wear off. Now, the last category we'll talk about is our nerve stimulation and our response to that. So we'll describe a few different scenarios. We'll say the normal patient before they have their blockade. We have our block in action. And this will be describing our train of 4, which is probably the most common way that we monitor a patient's twitches. And then we can also describe post-Titanic stimulation. And so what we see with our normal patient with rocuronium compared to our train of 4 when they've had a block is we see fade. And so what we'll end up doing is giving a stimulation every 0.2 milliseconds, and this will end up having less and less response from our nerve cell. And this is a little bit different from what we might see when we give a tetanus, which would be showing fade too, but giving this stimulation significantly more frequently, so potentially at 50 hertz or 100 hertz, which is different from our train of 4, which is at about. So what we're seeing here is a fade in the response of our train of 4. And so our train of 4 is essentially 4 beats, lasting 0.2 milliseconds. And these 4 beats are given at about 2 hertz, which means that you'll deliver all 4 beats in essentially 2 seconds. And so this ends up leading to a slightly decreased muscle contraction each time you hit them with that stimulator. And this is a very classic phenomenon seen with our non-competitive, non-depolarizing agents. Now, we also have this ability to give, and tetany will be applied at maybe 50 to 100 hertz. The same 0.2 milliseconds potentially, and you can run it for as long as you want. So often people might do this for 1 to 2 seconds, maybe even longer, depending on how long you want to see this tetanus for. And just like we see with the train of 4, we see a fade over time with our muscle as it goes towards further and further contraction. Now, what we also have noticed is that there's something called a post-Titanic potentiation, where we end up finding that we actually get a giant jump in our muscle contraction after we've performed a strong stimulus or strong tetany. And so this is important because we end up seeing a very different response. And so we can describe normal response to potentially a train of 4 in a patient who's not blocked. But we notice that this response, when we have a blockade on board with succinylcholine, is reduced by a certain percentage, but we don't see this train of 4, and so we don't see fade. So this is no fade. And then similarly, when we see our tetany and we apply multiple responses, we don't end up seeing any type of fade with that tetany. And at the same time, we still see this post-tetanic stimulation or post-tetanic potentiation. And so this looks very different from our normal non-depolarizers. And the thought is that this happens because of potentially pre-junctional receptors. So as we talked about, we had our pre-junctional receptor, which is a little bit different from our post-synaptic receptor, and that this has an alpha 3 instead of alpha 1, and it has a beta 2 instead of a beta 1. And so this has a slightly different response potentially to our neuromuscular blockers. And so what can happen with our pre-junctional receptor is that rocuronium can bind here and prevent us from getting our further increase in calcium, which would normally happen with positive feedback from our acetylcholine molecules binding to this pre-junctional receptor. Since we block our calcium here, what we're ending up doing is removing an ability for further synthesis and mobilization. And so when our calcium normally increases, we can have further synthesis of our vesicles with our acetylcholine molecules, and we can move or mobilize our reserve pool of acetylcholine to our surface to have a more immediate release at our surface. And so both of these thoughts are likely why we see fade with rocuronium, because we can end up having further mobilization of our acetylcholine to drop into our synaptic space, which means that when we have our first signal down, we end up releasing most of our acetylcholine that's at the immediate surface of our nerve terminal. And so because we've used up a lot of our vesicles in our first response to a nerve stimulator, the second train of 4 comes down, even less of our vesicles are available, potentially release more acetylcholine. And with our third one, we have even less, and our fourth one, even less than that. All because our rocuronium is preventing us from having a positive feedback and creating further mobilization of our acetylcholine to our synapse. Now, in comparison, succinylcholine doesn't bind to our pre-junctional receptor, at least in low concentrations. So this could be either rock binding to our site or high doses of sux. But normal doses of succinylcholine won't be able to activate our pre-junctional receptor, which means that when we get a nerve stimulus and that first part of that train of four hits, we'll have a normal amount of vesicles synapsing with the membrane. And with our second train of four, because we still have positive feedback, we can have more vesicles synapsing with our nerve terminal. And our third one, the same thing, and fourth ones. And so what we end up having is a very constant amount of blockade because we don't have any amount of positive feedback. Now, I will mention that there is an ability for high dose succinylcholine to bind to this pre-junctional receptor and probably cause a similar decrease in synthesis and mobilization. And so what this is being classically described is phase 2 block. And so what we would see here is essentially the same blockade for a normal patient, but we'll see a very similar fade that we see with our non-depolarizing agents like rocuronium. So these are very, very similar. And as well as we'd expect that our tetany would also show fade, and we would still see our post-Titanic stimulation. And so what we notice is that both our train of four and our tetany are both very similar in our phase 2 block of succinylcholine compared to our non-depolarizing ROC. And so this is essentially when we've given too much succinylcholine to our space that we end up having a significant blockade, and it can last much longer than our normal blockade of maybe 8 to 10 minutes with succinylcholine. And finally, we'll mention the idea of tetany and the idea that you get a post-tetanic potentiation. And so the idea, what you end up having is a large amount of intracellular calcium because our channel for calcium stays open for this is our P voltage gated calcium channel. And so with so much intracellular calcium here, what you end up doing is stimulating a large amount of synthesis and mobilization. Both of this will lead to a far larger amount of vesicles that are able to fuse to our surface and unload into our synapse. This will allow us to potentially see a more sensitive idea of where our patient may have neuromuscular blockade. And so what we see is a larger response to our nerve stimulator after you've given it tetanus, and this will last for 1 to 2 seconds afterwards. And so sometimes a patient may have a certain amount of block where we can't see any train of four, and train of four is essentially 0. But we need to differentiate between a super deep block and a normal deep block. And so what we can do is we can do a Titanic stimulation and then stimulate them right after, do this post-Titanic potentiation, and see whether we see any type of stimulus afterwards. If we saw a positive post-Titanic stimulation, then we would know that there's still some amount of blockade, but this is relatively deep. While if we didn't see a post-Titanic fade, then that means this must be a very, very deep block, because even post-Titanic stimulation hasn't been able to see a response in their muscle twitch. Now, oddly, we do find that similarly to non-depolarizers, a phase 2 block can respond to some amount of acetylcholinesterase inhibitors. And it's not really well worked out exactly why this works, but essentially you can potentially reverse a little bit of a phase 2 block by giving our normal reversal agents. The only problem is that this response to acetylcholinesterase is very variable. and potentially inhibiting our pseudocholinesterase, and difficult to try to assess what might actually happen when we give acetylcholinesterase inhibitors to a phase 2 block. And so it's essentially recommended that we don't. And then the last thing I'll mention is that there are potential for agents to act at the pre-junctional synapse that's irrespective of this pre-junctional receptor, where it can potentially affect our calcium channels. And so magnesium might potentially inhibit our ability for calcium to come into our cell. And this is one of the thoughts for why magnesium has the ability to potentiate our neuromuscular blockade or cause some form of muscle relaxation. This is not the same as our calcium channel blockers, because our calcium channel blockers inhibit L voltage. So this should help to understand what's happening at the molecular level for our different types of depolarizers, and it'll help to understand our next sections as far as what's happening with some of our effects.